Last heavy lift of our chapters because so many of our patients will have anti-diabetic medications that you'll have a lot of these. I do want to point out in the Sure Path that there is a really good lesson that's available to you. I think it has 2 osmosis videos in it. It's a hefty lesson. It takes a little over an hour to get through, but I would encourage you to do that so that you understand this chapter thoroughly. And then also pay attention to your core, this chapter outline and then the notes that I've given you for this one. As we go through, I almost my problem with the key terms is you have to know all of these. It almost seems a little counterintuitive because I understand you haven't had a lot of the medical um, uh, adult physiology of this point at this point, but if you understand the terms here, it will help you as we work through this chapter talking about diabetes and those anti-diabetic drugs. Goes into a lot of detail about our pancreas and the pathophysiology behind diabetes. I really want you to understand the gist is that our blood sugar is not getting where it needs to be in the cells for use so that it is circulating within the bloodstream. If it's circulating within the bloodstream, it's not available to our cells for use, and it gives us a hyperglycemia. So pointing out that term, I think that was mentioned at the very top. Um, when individuals are diagnosed with diabetes, we usually see these 3 Ps here. So polyphagia, so lots of eating, polyuria, lots of peeing, and polydipsia, lots of drinking, because their bodies are starved for glucose, but it's not in the cells where they need it. And then there's some key terms here about what our glucose should be. We have 2 types of diabetes that we'll talk about briefly in this chapter. Type 1 diabetic, we used to call it juvenile diabetes. These are individuals whose pancreas does not produce insulin. So think of insulin as the key that gets glucose into the cell. They do not have insulin. They are going to require insulin throughout their life. Versus type 2 diabetes, and we usually see these in conjunction with weight gain. It can occur anywhere in life. It used to be something that occurred later in middle age as people put on more weight, but we're starting to see juveniles get type 2 diabetes as they're becoming more sedentary and overweight. With our type 2 diabetics, um, hopefully I can control their blood sugar with oral anti-glucose agents. If that's not possible, then we can add insulin to their repertoire. Often I've seen type 2 diabetics do great when they're at home with their oral anti-diabetic medication, but when they're in the hospital because of the physiological stress, we might have to cover them with some insulin while they're in the hospital. With the type 2 diabetics, they do make insulin, but they either don't make enough or they are not as they're insulin resistant. So their body doesn't recognize this insulin as well as it should. So keep those things in mind when we're talking about the overall gist of our diabetic patients. Get you some different characteristics noted here. And I've got lots of information on both the course outline and the medication teaching notes for this. Goes into a lot of detail about why what we're seeing when we have these individuals. Do want to point out these 2 things here: diabetic ketoacidosis and hyperosmolar hyperglycemic syndrome. So there's some key notes here on when we usually see these. I want to point out the serum glucose level. So usually under 200, but still significantly high. So over our usual range of 150 all the way up to 600, and then hyperosmolar hyperglycemic syndrome will be a blood glucose level over 600. So keep that in mind there. And then I do want to point this out because I'm always wanting to point out the non-pharmacological stuff. For type 1, we can't do anything for type 1. They are going to have insulin therapy. For type 2 diabetics, if we can get a tight grip on their lifestyle, we can either postpone or even delay or even make it where they don't need anti-diabetic agents, because that weight loss typically makes them more susceptible to their insulin. So hopeful that would be my personal goal, to get them moving, get them on a different diet, and stopping smoking, stopping alcohol consumption, and that regular physical exercise, so that they don't need diabetic agents. However, it's a lot easier to pop a pill than it is to do all that stuff. So that seems to be where we have individuals fall. I do want to note that hemoglobin A1C level is a much better indicator of individuals' blood sugar over a course of 2 to 3 months versus a fasting blood glucose level. So for most of our patients, we'll pay more attention to their hemoglobin A1C. When we get into our medications, it's like, keep in mind that for our type 1 diabetics, we are going to give them insulin. It's exogenous insulin, meaning we're giving it to them because their body does not make enough insulin. And there are a couple of different types of that insulin. Here's a good note of some of those different types. And then literally throughout the rest of this chapter, you have to take each insulin at a time. We have to look at rapid acting insulin. We have to look at short acting insulin, intermediate acting insulin, and long acting insulin, as well as fixed combination insulins. They're showing you here the specific type of syringe that we use to draw up insulin. It's usually has a green cap, and on the syringe itself, it's in units, not milliliters. So keep that in mind when we're seeing that. With our different with our different insulin types, the rapid acting, this is showing you how quickly it works versus the regular acting. It works also fast, pretty quickly, versus the NPH versus the glargine. So you can see here that a lot of our patients will take multiple different types of insulin so that we have a better ability to stabilize their blood sugar. So one of these would work fast, and one of these would work more over the long-term use. So it's very common that we will give patients more than one type of insulin. For my rapid acting insulin, I want you to recognize the term Lispro. And on my Lispro, it's going to work within 15 minutes of giving. So we want to make sure those individuals have a meal available so that we don't throw them into hypoglycemia. Note that before you give your insulin, usually we have to check this with 2 nurses before we give it to our patient. And we'll also want to know what that patient's blood sugar is. So note what their blood sugar is, check your dosage with 2 nurses, and then making sure that we have a meal available for them quickly because we know that's going to drop their blood glucose fairly rapidly. My next one is my regular insulin. This is my short-acting insulin. I can give this one not only in an injectable form, but this is the only insulin that we can give. Regular insulin is the only insulin we can give IV, and we'll talk about that a little bit in class. There's our clinical pearl on that one. My next insulin, let's see, what did I want to say about that one? On my short-acting, my regular insulin, it usually begins to work fairly rapidly, not quite as quickly as the 15 minutes, but usually around 30 minutes, it's going to start to work if it's given in sub-Q format. And then it has a short half-life, so the duration of it is only about 6 to 10 hours, which means we're going to have to monitor for their blood sugar dropping after that, or give them a different type of insulin to cover for that. If I give it IV, it's immediate action, and it will work on that individual for as long as we give that IV. In the hospital setting, it's very common for us to have a sliding scale insulin that will use regular insulin to cover our patients' their blood sugars or Accu-Checks. So usually the order is for Accu-Checks to be done AC and HS. So that would be 730, 1130, 1630, and 2100. So I'll get those blood sugars, and then I will cover them based on what that blood sugar is. For most orders, if their blood sugar is between 0 and 150, we don't give them anything. And if it's between 151 and 200, we might give them 2 units of regular. If it's between 201 and 250, we might give them 4 units of regular, and so on. And then there will be a high-end cap that says if it's over X, usually 250 or 300, to notify that healthcare provider. Moving on down to my intermediate insulins, these are going to work in about an hour to 2 hours, and they're going to work for up to 18 hours. So you can see where I might add some intermediate acting insulin with my regular acting insulin. So my regular insulin would get to work right away, but then when it starts to the duration tends to go down, then my intermediate insulin would work. And my intermediate insulin is known as NPH. This one's a cloudy form, it mentions that here, versus regular insulin being a clear form. My next one are my long-acting insulins. These are going to work in about an hour to 2 hours, and they're going to work for up to 24 hours. So great coverage on this one for the longer term use with those individuals. And then we can go down into some fixed combination insulins where I have two different types. When they have two different types, the rapid one is usually the first one that we mentioned there. So it will have that will be the second one. So if I have a 70-30, that 30 is usually the short acting, and the long acting is usually the first number that you have there. So that will prevent me from having to stick my patient twice. It will give one injection. We'll have both the rapid acting and then the intermediate acting with that one. Most of our patients, if they're a type 1 diabetic, and they've had it for a while, will be on, instead of giving themselves injection, they'll be on a pump, which will monitor their glucose, and it will give them the insulin that they need in relation to what their blood glucose is. Those patients do have to very carefully monitor to make sure they don't go into a hypoglycemic state, and they want to make sure that they have some sort of glucose available to them at all times. If my patient's a type 2 diabetic, we're going to go into my non-insulin medications, and these are going to be oral medications. So my first group here is my Bigans. My first drug of choice for this one is metformin. So if I think about metformin, let's see, my interactions here, they shouldn't take the metformin therapy or the metformin drug if they have to have any type of radiological study that has contrast media. So we would have to monitor their blood sugar and use something else during that time. Metformin's my most common oral medication that we'll use with these patients. And because it does have a lot of GI upset, we'll start them with that low dose and titrate up. My next group are my sulfonamide, or my sulforia, excuse me. All my sulforias are the second group. They've been around for a long time. They have some really good control of our type 2 diabetics. My drug of choice, we do want to watch for hypoglycemia if I give it with insulin. So think about that patient in the hospital. They might be taking an oral sulfonylurea every day, and then we have to cover them with insulin. So we'll want to make sure that we monitor their glucose level, make sure we don't throw them into hypoglycemia. My next group are my glycosides, I believe. On my glycosides, kind of the same thing, how we roll down, and we're just evaluating how they work. I have two drugs listed on that one, my Prandin and my Starlix. And then I have the final one is my Blackstone, which is my Actos for this drug. I do want to scroll to the bottom here and look at some of my indicators. So all of these are going to work on my patient's blood glucose level by providing that insulin that they need to get the glucose into the cell. So because it's doing that, the biggest side effect could be that it throws my patient into hypoglycemia. So when I have hypoglycemia, those signs and symptoms are confusion, irritability, tremor, sweating, with later symptoms of hypothermia and seizures. For these individuals, if they're alert, we usually give them an oral glucose of some sort. And if they're not alert, we'll push D5W on those individuals to get their blood glucose back up. Lots of assessment with these individuals. So we want to make sure we understand what their glucose level is, what we're giving them, when it's going to peak, and how long it's going to act, so we know when to monitor for them to have hypoglycemia